Good morning. I'm Michelle Lavander, Director of the University of Southern California Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Profiteers of Tragedy, Making Money Off America's Opioid Addicts. This webinar is offered thanks to a generous grant from the National Institute for Healthcare Management Foundation. Yesterday, President Trump formally declared the opioid epidemic a public health emergency. Long before that, America knew it had a problem. But less well known about the scourge is the existence of an illicit industry that has sprung up to profit from new healthcare benefits for addiction treatment, with brokers selling patients like commodities to fraudulent sober homes and to questionable treatment centers. Here to talk about this burgeoning shadow industry and how to report on it, as well as what the best practices are in legitimate treatment centers, we have four experts. Evan Allen of the Boston Globe's narrative news team, and David Armstrong, a senior enterprise reporter for STAT. Together, these two award-winning investigative reporters have covered the opioid epidemic in an ongoing series since April. And David Ehrenberg, state attorney for Florida's 15th Judicial Circuit in Palm Beach County. He's a former assistant attorney general, White House fellow, and Florida state senator. As state attorney, Mr. Ehrenberg leads a team of 120 prosecutors and 220 staff in 5 offices throughout Palm Beach County. His Sober Home Task Force has received national attention for targeting fraud and abuse. And we have Dr. Keith Humphreys, a professor and the section director for mental health policy at Stanford University, a senior research career scientist at the VA Health Services Research Center in Palo Alto, and a former member of the White House Commission on Drug-Free Communities. He also currently blogs for the Washington Post's Wonk blog. Before we get started, I wanted to share a few operating procedures. We'll hear first from all of our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. We also encourage you to tweet about this webinar at the hashtag opioid crisis. We'll also be archiving this webinar at centerforhealthjournalism.org. So let's get started. David, please paint a picture for us of the scope of this problem.
Sure. I think that it's fair to say that this is certainly a national problem, and that abuses in the treatment industry for people suffering from addiction, particularly opioid addiction, are widespread. The reason that I and Evan became interested in this is because we heard from so many people who were searching out treatment options for loved ones, and were really confused about the information they were receiving. There's so many different options out there. There's not a source that they considered a go-to source for finding good treatment. So we decided to poke around and look at sort of what the options are and what's happening in this industry. So one thing we found, and this is what we first started writing about earlier this year, is that there is a brisk business in the trading and brokering of people who are seeking addiction treatment services. Heads for beds is one of the phrases we heard. And basically, the way this works is people are recruited into treatment. Oftentimes, this is done by people who are in recovery themselves and who are being paid by treatment centers or referral services who get paid and sometimes paid in kickbacks by treatment centers to get people to go to certain facilities. And this is happening all across the country, but obviously a lot of it's centered in areas hardest hit by this crisis. So we found a lot of people in New England, the Midwest, and other parts of the country where this has been particularly prevalent, that are experiencing this brokering issue. And it's really a network and a web of people that are engaged in these practices. And one of the things that we found was that to make this work, the patient brokers were helping the people who need addiction treatment enroll in fraudulent insurance plans. And then the second part of that is helping them then travel to often out-of-state treatment centers for services. And I'll explain a little bit more about how this works as we get going. And then the other thing we found is law enforcement cracks down. You're going to hear from Dave Ehrenberg in Palm Beach County, which has done a really terrific job in going after bad actors in this field. We're now seeing some of these treatment scams move into areas where they had not really been as active before. And even within states, so you have a situation where Palm Beach County has a task force, but other counties don't have task force, and some of these treatment providers are now moving just into other counties. So let me give you an example of what I was talking about with the fraudulent insurance. In one case, we uncovered, this is a photograph of Peter Santangelo, who is a Boston area man. He was contacted by a broker and offered a chance to go receive treatment in several locales, you know, from California to Florida. And he opted to go to Florida. But first he had to get the insurance that's preferred by the treatment centers. Peter had essentially what is Massachusetts Medicaid, but that's not going to work in out-of-state facilities, and the reimbursement rates aren't as generous. So they fraudulently enrolled him through the Health Connector into a Blue Cross Blue Shield plan in Pennsylvania. And they used a fake address. They actually used an address of a sober home in Pennsylvania to enroll him. And this is shockingly easy to do. And by the time the insurance companies get wise to it, well, the person's used all of their benefits, and the treatment center and the patient have moved on. So we talked to dozens of people who are brokered this way. Many found out that they were brokered in the same fashion when they met in treatment. And in some cases, they found out that they had the same bogus address in places like Pennsylvania, everything from abandoned properties to sober homes to, in some cases, if somebody had a relative in a state that offered good insurance that the treatment centers wanted, they would sign up multiple people at that address. The most popular plans that paid really generous out-of-network benefits tended to be Blue Cross Blue Shield plans. And the brokers would, and eventually some of the patients would joke about it and say, do you want to Blue Cross the country? In other words, if you had that high quality Blue Cross insurance, you could go into pretty much any treatment center you wanted to. So the kickbacks, so the way this works, generally speaking, is that the treatment center pays marketers or brokers to recruit patients. And again, as I said earlier, oftentimes this is done within the recovery community itself. Brokers will go to AA meetings or NA meetings to meet people in need of treatment. They'll go to advocacy meetings, you know, where people are talking about solutions to make connections to those people because they want to identify people who are relapsing or seeking treatment. And then they also have call centers and websites that will advertise for people in need, and these people will sell leads to brokers. So there's a whole bunch of different ways that people find out about, or brokers, I should say, find out about people in need of treatment. And then another part of the chain is these licensed insurance brokers who have easy access to the healthcare portal and will sign up dozens or scores of patients for a broker. They make it very easy. They know how to do it. And they also oftentimes know which addresses to use. So that's another part of the chain. And everybody gets paid out of the money that the treatment center collects from the patient's insurer. And just before I move on to sober homes, I just want to say that we're talking significant amounts of money. You know, $25,000, $30,000 a month, sometimes coverage 30, 60 days, in extreme cases, maybe 90 days. So the cost of paying a broker, which can be $500 to $5,000 a head in some cases. Well, that's a small price of doing business when you're able to bill at the rates that a lot of these unscrupulous treatment centers do. Another element to this is sober homes, which I know Dave Ehrenberg will talk about in more detail. But the way this works is that the sober homes often work in concert with the treatment centers because they have patients. They have people that are often relapsing and need treatment. So they're involved in illicit relationships with the treatment center where they might provide patients for them. The treatment centers kick them back money or give them other things of value like free vans. And then the treatment centers get to bill all over again. The sober homes in most states are lightly, if at all, regulated. These are facilities where people in recovery live together, but the rules about who can own them, how they're operated, how much you charge people to live there, it's really the wild, wild west. And there's a lot of really terrible sober home operators who are doing a great disservice to people seeking treatment. So on this last slide here, before I turn it over to Evan, just a few sort of 30,000 foot viewpoints. This is a big industry, the treatment industry. There's different estimates out there. The federal government has used one of $35 billion. I think one of the things that's really surprised Evan and I is that it's not so much an issue of access to treatment anymore, although that is still a problem for people, but getting better after passage of things like the Mental Health Parity Act and other things like that. Insurers are generally starting to be better about paying for this. What we were shocked by is a couple of things. One is the weak state and federal regulation. Both the Palm Beach Post and the Orange County Register and others have done some really terrific reporting on how ineffective, short-staffed, really, some of the states are in terms of regulating this business. In California, there's a handful of employees who are responsible for inspecting, regulating, and licensing treatment centers in a state that's just flush with them. And then the other interesting thing, and I know Keith Humphreys will talk about this later, is there's many kinds of treatment that get reimbursed. And there's some really strong feelings among people about what the best treatments are, and then there's sort of what the science says. But most of the treatment is 12-step abstinence-based treatment, which, if you look at the record there, in terms of outcomes, is not really great. And then there's medication-assisted treatment, which the science suggests does a better job in terms of relapse prevention and helping people get into recovery for longer periods of times. And then there's a range of programs, inpatient, outpatient, sober living homes, as we mentioned. So certainly for people looking for treatment options, it gets very confusing. And even insurers themselves really just don't have any standards here. They basically pay for all of these various kinds of options, whether or not there's good scientific evidence for them or not. And then, of course, and again, I think Dr. Humphreys talked about this some more, even with good treatment, can you hear me okay? Even with good treatment, there's still a high relapse rate, and sometimes it takes multiple attempts for people to get into long-term recovery. And then finally, the people that we've been talking to, the people that are victims in this brokering and trafficking scams, are people that have substance use disorders, and there's still some stigma attached to that, and they're not always believed. They're easy to dismiss by some people when they say that they've been taken advantage of. So that's something to keep in mind, and I think by doing these stories, we're giving power to those voices. So I think at this point, I'll turn it over to Evan, who is going to talk more detailed about some reporting tips and different documents and areas you can go to get more information on what's happening in these treatment facilities.
Thank you. So I'll start with some red flags to watch for. These things don't always mean there's fraud going on, but we have found them to be good indicators that it's worth taking another look. The first is treatment centers that are promising luxury or 5-star accommodations. So you look at the website and it's all palm trees and black car service, spray tanning. We saw one that had an ice cream machine. Often they'll offer things like acupuncture or massage. It's not that there's anything wrong with getting a massage. It's that these things are not what addiction treatment is about. Often these types of luxurious offerings are used both to lure people to these locations and also to justify raising the price of treatment without raising the effectiveness of treatment. So if treating addiction was as easy as putting someone in a beautiful location, we would just send everybody to the Ritz-Carlton and we wouldn't have an addiction treatment problem in this country anymore. So looking at places that are sort of focused on the wrong thing is a good way to start looking at places that are maybe doing the wrong thing. We saw a lot of social media marketing that promised free treatment in other states. One of the things that's sort of striking about how this whole scam works is a lot of it is conducted right out in the open on social media. And so you see people, I can get you to Florida, I can get you to California, where do you want to go? But keep in mind that treatment is not free. Someone is paying for it. And if it's not the patient, then it's probably the insurance company. And if the patient isn't paying for their airfare or for their insurance, then that means that someone else is paying for their airfare and their insurance. And so that person is making something off that. They're not doing it out of the goodness of their hearts. One thing that we saw a lot of was deaths of people from out of state at treatment centers or sober homes. This is a red flag because if somebody from Minnesota is dying in Florida, you have to ask how they wound up in Florida. And we actually found that by tracing those deaths backwards, we were able to find family members who they had no idea their loved one was brokered, but all of the telltale signs were there. Like, oh yeah, they did have free flight down. They did have new insurance. And so you don't even, the families often don't know that this has happened, but when you identify the person who died, you can start to figure out the network that brought them there. Patients who don't know their airfare was paid for, or that don't know their insurance, or patients who say their airfare was paid for, or who don't know their insurance information, those are obvious flags for having been shipped out. We heard that from almost everybody that we talked to. They had free flight and free insurance. A lot of them don't know their home addresses on their insurance, or they've never been to the place where their insurance is out of. And then also patients who say that they were urine tested multiple times a week. Urine tests are very lucrative for treatment centers. We heard about people being tested multiple times a week and sometimes multiple times a day. Insurance centers can bill your insurance hundreds and sometimes over $1,000 for a single test. We've heard stories about men getting included in pregnancy tests in some of the urine tests that test for multiple things. So those can be a way to really drive up the bills. So you always ask about urine testing. So victims and their families were some of our very best sources. So we started a lot of times with support groups or advocacy groups for parents and families that have lost people to addiction. This brokering is taking place in a very open way oftentimes, and advocates who are trying to do the right thing have pretty strong feelings about it. It's usually pretty well known, we found, who is brokering and who is really trying to help people. And if you can sort of get embedded in some of those advocacy or family groups, you can usually start figuring out who's doing what. One thing that we had really good luck with asking families for was cell phone records and Facebook messages. Because again, a lot of this is conducted on social media and via text messaging. So you can get really good real-time breakdowns of how this whole scheme unfolds. With Peter Sanangelo, the patient that David showed a picture of early on, we were able to get long cell phone text message records that showed exactly the mechanics of the scheme as it was happening, and who's calling the insurance, and who's pretending to be a girlfriend to try to get access to the insurance, and who's sending a fake address. This is not, they're not really hiding it very well. They're leaving quite a paper trail. And the other thing to keep in mind is that anybody who was brokered to a treatment facility wound up surrounded by other patients who are also brokered, because the treatment centers are in on this whole scheme. So it's not like you're going to have one brokered person at a treatment center. So if you can get into the network by finding one person that was brokered, you can usually work through their connections to find a whole bunch of other people that were brokered. And we found that many people were brokered multiple times to multiple different treatment facilities, often in multiple states. Some really useful documents. We tend to start with the State Department of Public Health, which here in Massachusetts, they license and oversee treatment facilities. It may be in different states that other departments do that. But usually there's at least some licensing and regulation of inpatient treatment facilities. And so you want to be looking for any complaints, investigations, or corrective action plans that the state issues to each of these places. In some states, I believe in most states, facilities are required to report any deaths to the licensing body, and there's usually an investigation that is triggered by that report. So in Massachusetts, for example, we knew about a month ago, there had been 9 deaths at treatment centers in Massachusetts statewide this year so far. So you can ask for all the deaths statewide and all of the reports generated. Oftentimes they'll hide the name of the patient, but if you can get a death certificate using the location and date of the death, then you can usually connect it with a human being. A note on death certificates though, even if a person overdoses and dies and the overdose occurred at the treatment center, they often will not be pronounced until they are at the hospital. So if you're looking up death certificates by location, which you can do in Massachusetts, you should be looking at place of injury as well as place of death, because oftentimes the treatment facility will show up as the place of injury rather than the place of death. Joint Commission and CARF are 2 accrediting bodies. They're not particularly effective in terms of overseeing treatment facilities. However, they are very useful for reporting purposes because they list the addresses of treatment facilities, which are often hidden on the websites of treatment facilities. That's for privacy reasons for patients, and so people can't just show up at treatment facilities. But Joint Commission and CARF can help you get that information, which will allow you to request things like police reports and police call logs for each address. We did a lot of that, looking for patterns of overdoses and violence and people leaving against medical advice and having the police called, and strange cars coming by, because sometimes that can signal that there are drugs being bought or sold at the facility. Physician licensing and disciplinary documents were really helpful, because a lot of treatment centers that are running these scams are, as you might imagine, run by people who are unscrupulous in other ways. So we have found that some of these physicians operating these places have a very checkered past. We spent a lot of time checking people on different corporate databases, because a lot of people who are running treatment centers, they're also running all sorts of other programs. They're running marketing companies, sometimes they're running sober homes, which they, so you can see if they're running a whole bunch of different related businesses, you can start to look at what other property they own under different corporate names, and start to create a network of like what these individuals own. And a lot of times you'll find that, one hand washes the other. They're funneling people from their treatment center to a sober home. Pacer is really useful too. We found a lot of people that we looked at have past bankruptcies, which just helps to explain why they are making money in an illicit way. And then I think we touched on this a little bit, but social media was incredibly helpful in our reporting here. A lot of the people that you're dealing with in these schemes, who are victims of these schemes, they're not people that are going to go file formal complaints or file police complaints. They're going to complain on social media, they're going to talk to their friends, and they're going to do it all in public. And we found that Yelp was really oddly effective in terms of finding people that had been taken advantage of, because a lot of these people, like, they'll leave a complaint on Yelp and move on. But we were able to track a lot of people down that way. The downside of Yelp is that people aren't always using their full names, but a reverse Google image search can often link the image that they use to other social media profiles, and you can find them that way. So, we spent a bunch of time, and we still spend a bunch of time, just looking through people's Facebook pages, looking through their Instagrams, and figuring out who they're connected to, where they've gone, who's commenting on their posts about different treatment centers. And we do this for both the victims of this scheme and the perpetrators, because they're all interacting all together, often on the same pages.
Thank you so much, Evan. We're going to turn now to State Attorney Aaron Berg, who's been working on this problem in Palm Beach. Can you tell us what prompted you to launch your Sober Homes Task Force?
Sure, and thank you for putting this webinar on. And David and Evan did an excellent job describing the problem. It's issues like that that prompted us to start our Sober Homes Task Force. You see from the picture on the left, that's what we used to go after, oxycodone. But a lot of the people who own these pill mills to sell oxycodone have moved over to heroin, which is cheaper and more accessible these days, or they just own these clinics, these treatment centers that have made this opioid epidemic so much worse, that are exploiting people at the lowest stages of their lives for profit. And David and Evan did a great job in describing the problem. And that's why we started this. Why Palm Beach County, though? Why is Palm Beach County so much worse than other places? Well, Florida had, for years, this deregulated environment when it came to the sale of oxycodone pills. We, as you can see from this graph, we had doctors being able to not just prescribe, but dispense this medication. And so this is when it peaked in the first 6 months of 2010. This was the peak of the problem. You see Florida with more than 41.2 million doses of oxycodone purchased by doctors for the first 6 months of 2010. And the next biggest state was Ohio, with just over 1 million. But here's another way to look at it. On the left is Florida, and on the right is every other state combined. So this was going on while the legislature refused to deal with the problem. We continue to have almost just about zero regulations. Anyone can open up one of these pain clinics, and you had carnage, 7 deaths a day. You had more pain clinics in Florida than McDonald's in Florida. And eventually, after a decade of this in 2010 and then 2011, finally the legislature passed some reasonable regulations, including a prescription drug monitoring program, and that resulted in a decline right away in prescription drug deaths. You saw some good news right away, including a 63% decrease in oxycodone deaths. But government does a better job of reacting after a crisis has occurred. It doesn't do a great job of preventing and anticipating to alleviate an epidemic before it happens. Government is better at just reacting after it reaches a critical mass. And so what you see is that we knew that as we went after the pain clinics and the pill mills and the oxycodone abuse, that users would then move over to heroin. The dealers would then move over to heroin, either dealing heroin, or then we later found how they're exploiting the system in these corrupted rehab centers. But as you can see, the carnage after going down for a couple years just increased, and now we're dealing in Florida with about 10 deaths every day from this, and we expect maybe 14 deaths when the statistics come out in 2014. And that's because of the rise in heroin. You can see the inverse relationship between oxycodone deaths and heroin deaths. Once one goes down, the other one goes up. But this isn't your grandfather's heroin anymore. This is heroin laced with cheap, potent Chinese fentanyl. If there's one thing that the federal government could really do to make a real difference, I mean, there's a few things. I'm going to get to that. But right away, it would be to convince the Chinese government to stop the easy exportation of this fentanyl that is poisoning so many people. We really don't have a heroin epidemic. It's a heroin fentanyl epidemic. And nowadays, the fentanyl is joined by carfentanil, another analog. That's an elephant tranquilizer that is about 1,000 times more powerful than fentanyl. I mean, it's really, when we first saw it on the streets, we had to go to a zoo to test it because we didn't know what it was. It's carfentanil stuff. So that's what we're dealing with. And you wonder why then, do I mention the federal government as being, the government being complicit in this? It's not just inaction by the government. It's not just ignoring it. It's enabling and exacerbating the problem through its laws, well-intended laws that have made things worse. You have the Americans with Disabilities Act and the Fair Housing Act, which are well-intended, but have been exploited by really bad people, as David was saying, really bad actors, to open up flop houses. Sober homes are just houses here. They're just a place where individuals in recovery live together in a group setting. It's supposed to be in a drug-free environment as they promote recovery there. There's no treatment there. There's no insurance reimbursements. It's just a house. But local governments have been stymied at trying to regulate them, inspect them, certify them, register them, because the federal government, under the Americans with Disabilities Act, says no, they're protected. You know, the ADA was never intended to protect flop houses, but that's what's going on. So instead of the ADA protecting individuals in recovery, which is what it was designed to do, it is contributing to their demise. As local governments and law enforcement, our efforts too, are stymied. We have one hand tied behind our back in this. Another federal law that's well intended is the Mental Health Parity Act and the Affordable Care Act, both of them, which provide generous benefits for individuals in recovery, such as, you know, you stay on your parents' policy to the age of 26. You can't be denied for a pre-existing condition. You have to have mental health and substance use disorder coverage. But these generous benefits are being exploited by profiteers for money. They take individuals with substance use disorder and they use and abuse them, siphon all their insurance payments as much as they can, and then when they're done, they just give them drugs to start the process anew. And because you cannot be denied for a pre-existing condition, there's no limitation on how many times you can go through this vicious cycle. So instead of a recovery model, we have a relapse model. And that's why you see people from all over the country coming down to Florida. And why Florida? Because Florida always had an established and very large recovery community, especially in Palm Beach County. We had a lot of legitimate rehab centers. And so, yay, you know, like Willie Sutton, why do you go rob banks? You do it because that's where the money is. Why do you go to Florida to exploit people in recovery? Because that's where they are. And the warm weather climate encourages people down here. And so you have 75% of private pay insurance patients, private insurance patients in Florida are from out of state. And once they're here, they're not leaving. Here's the model in theory. This is what's supposed to happen. You have someone with substance use disorder, a heroin addiction. They see an ad, they find out about a treatment center in Florida. They come down here on their own dime and they go to detox or inpatient treatment. Insurance will cover about 28 days. If you don't have insurance, you can get it through the Affordable Care Act, or you can get it on your parents' policy. After the 28 days are up, you go to an outpatient treatment center for outpatient care. That's what those initials mean, PHP, IOP, OP. It's partial hospitalization, intensive outpatient treatment, that's all it is. So you go for outpatient treatment where you get drug counseling and drug testing, a lot of your analyses. You get any kind of benefit, massage and whatever they provide. But that's paid for by insurance for about 8 weeks. But where do you live while you're there? Well, you live in a sober home. A sober home, which is just a group home. You pay about $200 a week and you live there. And the van picks you up every day and you go to the outpatient treatment center. And so for those 8 weeks, you live in a sober home off premises. And insurance does not pay for the sober home, so you pay out of pocket for that. But insurance will pay for the outpatient treatment. And then you're sober. And then you go home. And that's the model in theory. But in practice, it's very different. This is the Florida Shuffle. You have someone with substance use disorder being recruited to come down by a marketer to Florida, seeing a deceptive ad on TV, someone in a lab coat saying, hey, come on down, we're going to, treat you, we care about you. And so you call that 800 number, and it's just a marketer who gets paid to send you to whatever treatment center is paying them. So you get sent down to a treatment center, usually in Florida, and they send you a free plane ticket. That's a scam. That is illegal. The free plane ticket is the first crime. Well, actually, the first crime is the deceptive marketing. The deceptive marketing is a crime. Then they send you a free plane ticket, which is a crime, and then you go into the inpatient treatment. You may even get good care there, but after your insurance runs out in 28 days, where do you go? Well, the marketers get involved, and they push you to go to an outpatient treatment center that has a kickback going on with the marketers and possibly the inpatient treatment center. And so you go there and you get your treatment for 8 weeks. You live in a sober home. And how do you pick your sober home? Well, the marketer will help you pick it, or the outpatient center will help you pick it. And a legitimate sober home, which will charge $200 a week, will be, out there. But then you can also pick one nearby that is charging you $0, free. Why would you ever go to one that charges you $200 when you can live for free nearby? And the way that the sober home offers you free rent is because it gets a kickback from the lab that they're sending your analysis to. It gets a kickback from the outpatient treatment center because everyone who lives in a sober home is like gold to the outpatient treatment centers. They'll kick it back. This is all illegal, third-degree felonies, illegal patient brokering. And you notice that there's only one bubble on your screen where there's no money attached to it, no dollar signs, and that's sobriety. There's no money in sobriety. There's no incentive to recover in this process because it's hard enough to remain sober as it is, let alone knowing that your sobriety will also cost you your free housing, your free illegal gifts, your friends, and now you got to move back home to live with mom and dad in New Hampshire and find a job. No offense to anyone in New Hampshire. Just saying that in Florida, we've got all this sunny climate, and you got to move back home to a snowy climate or wherever you came from and find a job. So we have put a lot of pressure on these individuals who are battling addiction to try to do the right thing, and it's really incentivized for them to fail. The odds are stacked against them because the insurance benefits will renew, and the cycle can start again if they just test dirty. And there's plenty of drug dealers nearby the sober homes because everyone knows where they are. And if there's no drug dealer nearby, then you may get drugs from the sober home or from the marketer to get you back into this unending cycle. There was a woman named, we call her Jen, we have so many cases like this, but this is what we're trying to stop. And this woman, Jen, went through this cycle, and her mom called us on our hotline and said, please help us rescue our daughter from this. We told her, come down here now and get her out of there. She's in this Florida shuffle. But Jen refused to go back because Jen said, why should I go back? I've got everything I need here. She had free rent. She had friends and transportation, everything provided to her. As long as she stayed on drugs, she was doing okay until she leaves in an ambulance or body bag. So we created this Sober Homes Task Force. I'll go through this quickly. This is through a one-year appropriation. It was renewed last year with another appropriation. One thing that has not been reported as much is we also impaneled a grand jury, which issued a report. And one of the things we talked about in the grand jury report was how online marketers use Google search items to hijack the name and reputation of notable treatment centers to route the caller to another referral agency, meaning that people buy up search terms and then they go using deceptive marketing to those providers. You put in a search that says like rehab near me in Seattle, and up pops an ad of Seattle rehab that's actually in Florida, and then they send you the free plane ticket and off you go. Well, Google changed its policies, and the grand jury report was cited in one of the articles about why Google stopped advertising in that way. They're going to do it a different way now. So our task force has made 40 arrests since October 2016. So in the past year, we've had 39 felonies and 1 misdemeanor. 13 of them have already taken a plea deal of a guilty conviction on their records. There's jail time involved, but we're going to go to trial on the others and see if we can get prison. We have a toll-free tip line that is out there. throughout the country. It's not just for Florida. These are some of the individuals we've arrested. We also have two other groups, civilian work groups, that help us identify changes that need to be made to state law to help shake up and end this Florida shuffle. We had almost no laws in place. So we've actually had such a huge interest in this. The legislature told us to create a task force, but we were surprised at how many people wanted to be on this task force. We have two civilian task forces, one with doctors, industry lawyers, DCF, which is Department of Children and Families, FAR and FATA, which come from they're legitimate players in the industry. And then we have a larger group where just really advocates and clinicians and industry leaders. What happened was the proviso group, we were said, hey, you get 14 people on the proviso group, and they named these individuals or their titles or where they came from in the legislation. Industry, everyone wanted to be part of this, so I created this second group, this larger group. We have about 40 members, and they're well attended, and we meet twice a month, one for each group each month, and the meetings are like 5 or 6 hours long. The law enforcement task force, which received the most attention, has a full-time prosecutor, 14 officers from throughout the county, agencies donating their time to come loan their officers to us to investigate, arrest, and prosecute people who violate insurance fraud and patient brokering laws. And here's the law that we just passed as a product of the task forces. We have criminalized a lot of the deceptive advertising. We've strengthened the penalties against patient brokering. We've given the Attorney General statewide jurisdiction. So throughout Florida, it's not just going to be me here in Palm Beach County going after this. If this happens elsewhere in the state, the AG now can go after it. Even if the local state attorney is unaware or unprepared, the AG's office can go after it. Plus, we also do training sessions now for prosecutors and law enforcement throughout the state to teach them up on what we're doing and how to stop this, because it is going elsewhere. We have forced a lot of these folks out of our county, but the sad thing is that they're going up and opening elsewhere in the state and throughout the country. So the rest of the country needs to be prepared. And that's my last slide. I ended here with this. This was a picture of one of the notorious pill mills back in the day. When I say back in the day, I mean like 2010. And you had a bouncer at the front there with an iron gate. We shut all these places down because government just had the courage to do so. I'm hoping webinars like this can encourage action at the federal level, because as long as the federal government continues to pour money into these fraudulent treatment centers, you're going to continue to see a growth in the death rate. And the federal government can tweak, clarify, change federal law to help us. But until then, we're going to keep fighting this good fight on our own here locally. So thank you for your time.
Thank you so much, State Attorney Ehrenberg. We're going to turn now to Dr. Humphreys. We've heard a lot now about fraud and abuse in this industry, and we don't want to lose sight of the fact that the expansion of benefits for addiction treatment represents a very important advance. So Dr. Humphreys, tell us a little bit about models, quality models for addiction treatment, and what most people going through treatment programs are hopefully experiencing.
Okay, thank you. So let's talk through these slides fairly quickly. So why do we have quality problems at all in addiction treatment? And historically, one of the biggest issues was it was very badly funded. Prior to 2008, which was when the mental health parity law passed and Medicare started to cover addiction treatment, and then shortly thereafter, the Affordable Care Act expanded funding. Typical counselor might make, $7 an hour. A lot of the programs didn't have physicians. Is what you get bad quality when you don't pay. It's also true that the population is not seen as deserving of high quality care. So if a pregnant mom said, I was treated badly in the hospital, people would be outraged. But if an addicted person does, a lot of people would say, well, what do you expect? You're an addict. You don't deserve good treatment. Third problem is, and this fits in David and Evan's great reporting about where are the regulators, is that addiction treatment hasn't historically been part of medicine. It emerged from the criminal justice system and from the social welfare system, organizations like Salvation Army, and from 12-step fellowships. And those all three of those did good things, but none of them are subject to the kind of regulatory processes we have in medicine that, for example, ensures the quality of hospitals. So it's grown up as a separate industry, not well regulated. And then last, there's just a general problem. It's hard to judge quality in healthcare, not just for addiction. Ask yourself, what really is good quality, say, for cancer? Do you know, or arthritis or heart disease? Most people don't know. I'll give you an example of the low standards. There's a guy who says he's going to cure heroin addiction with marijuana. And I was really disappointed to see something like a dozen leading national papers gave him very respectful coverage in their papers. And I wrote something much more critical in Washington Post, as this is a fraud going back quite a long way. We used to say that we could treat alcoholism with heroin. We said we could treat morphine addiction with cocaine. But yet he got that respectful coverage. And I would submit to you that if somebody did this for cancer care, if they said we're going to treat cancer with marijuana, someone would be condemned. But in the addiction field, he was lionized, as an innovator. So, what is quality? You got to say whether something is good. You got to say what is the reasonable thing we can expect. And the first thing there is that addiction is a chronic health problem. It is not an acute problem like a fractured bone or influenza, where you put someone in the hospital for a day or two, or you give them a shot and they recover. It's a chronic health condition like diabetes or hypertension or HIV or lower back pain. And what that means is we can't cure it. We can teach people to manage it through behavior, their own behavior, by the patient, by the healthcare system. But it's not reasonable to expect that people can just go into a rehab and then 100% of them will be abstinent forever. And just to highlight the contrast of how the standards to which we hold addiction treatment rather than other things, we will say, when is he going to get off his methadone? His heroin addiction should be treated by now. But we never say, when will he get off insulin? His diabetes should be treated by now. We accept that diabetes needs long-term care. In addiction treatment, we hear people say, she was in the hospital for 21 days of addiction treatment. Why did she relapse? But we don't say she was in the hospital for 21 days for congestive heart disease. Why did she have another heart attack? We expect that people's health will still be challenging after that. And we also often blame patients for bad outcomes in addiction treatment. We say he failed at addiction treatment, but we don't say cancer patients failed at chemotherapy. What does good treatment look like? Well, first off, 90% of care in the United States is outpatient and run in clinics. So you're hearing about some very disturbing stuff about these super expensive rehabs. Just remember that is a teeny part of the industry. And to give you a context, David said it's a $35 billion industry, which sounds like a lot of money. But remember, we have an over $3 trillion healthcare system. So we only spend about 1% of the healthcare budget on substance use treatment. It is very little of it is in these, fancy rehabs. It's almost all outpatient clinics. And that can be very good treatment if you do the right things. There are multiple FDA-approved medications available, and they should be offered to every patient. Methadone and buprenorphine are opioid substitutes, and naltrexone is an opioid blocker, but these all have good research behind them as treatments. Many patients also need and benefit from psychosocial interventions, either in addition to medication, or if they refuse medication, as a sole intervention. We have psychotherapies, some of the 12-step and other mutual support group. Yes, some people don't do well in that, but it's also true some people benefit from them enormously. Randomized clinical trials, which are the gold standard in medicine when we want to see something works. There's actually quite a few of them of quality opioid addiction treatment, for example, methadone maintenance with counseling, and shows really big benefits. Mortality rates are dramatically lower. A heroin addicted person outside of treatment versus somebody who's in methadone would have about a 4 times as high risk of dying each year. Crime goes down, especially acquisitive crime. People are less likely to transmit and acquire bloodborne disease through the sharing of needles. That would be things like hepatitis C and HIV. Illicit drug use goes down and employment goes up. So these are all very valuable things that I think anyone who loves someone who is addicted would pay for, or if you just lived in a neighborhood with addicted people, you would say this has value. And this can be produced by high quality outpatient treatment, and is produced by it every day. What is it going to take to make quality normative? Well, part of it, you're going to have the continuation of the ACA and the Medicaid expansion. If you pull out huge sums of money, which taking those things away would do, we'll go back to just counselors, no physicians involved, crummy facilities. Whatever challenges we have now, they would only be worse if you pulled out almost all the money. Medicaid, my home state is West Virginia. Medicaid pays for half of all the Medicaid-assisted treatment of heroin in the state. Pulling that out would cause a collapse. The other thing is that these new insurance programs are integrating addiction treatment into medicine, which is a long-term project that we all need to support, because that's going to make higher quality by subjecting it to more regulation, by bringing in better staff, and making it easier for patients to access. We need better informed consumers. There's been Consumer Reports once did some work on quality and treatment, but we could have more, there's some companies working on that, but giving people information about which programs are good and which ones are bad. And then we also need to value the consumers. We have to start realizing that addicted patients are people, and if they're treated badly, it's wrong. It's just as wrong as treating a cancer patient badly. They have a right to expect that they'll be treated in a respectful fashion with treatments that have science base, just like anyone else would be. We also need more informed purchasers. I have a friend who ran a big company, very wealthy. He's in recovery from AA, and so he bought many insurance plans for his employees over the years with addiction treatment, and said what most people in this position say. He had no idea what he was purchasing. He had no idea how to buy good addiction treatment. He had no idea whether his employees were well protected or not. And that's true of almost everyone I know who works in business where they buy insurance plans for employees. We also need more law-abiding insurers. You've seen the exploitation of insurers, but just to put it, the experience elsewhere, Attorney General Schneiderman of New York has successfully sued a number of insurers who violated the parity law by denying needed quality care to addicted people who subsequently died. So we have the problem that David and Evan have documented so well of insurers getting ripped off and paying for bad treatment, but we also have another problem, which is sometimes insurers not paying for good treatment, which they're legally required to do. So we need to fix that problem as well. I'm going to stop there so we have time for questions.
Thank you so much to all of our presenters. I want to invite everybody to share their questions through our question panel. And we have a couple to start with. One from Karen Myers, who says, the patient isn't responsible for the insurance fraud, it's the facility, correct? I don't know, State Attorney Ehrenberg, do you want to take that one?
Yes. Well, if the patient is involved with it, he or she could be charged, but generally it's the provider, it's the marketer and the corrupted treatment center who gets charged. We haven't charged any patient unless the patient is also a marketer, and we've seen that where people who live there are being paid. Marketers pay individuals who go live in a sober home to encourage other people to go to a different sober home and treatment provider. They poach. And so, yeah, at that point, yeah, we'll charge. But an addict, we have not charged any addicts with patient brokering in the past year. No.
A lot of the people that we spoke to who had been victims of this and who had been enrolled in fraudulent insurance, they had been perhaps dimly aware that something wasn't right with their insurance. But you have to remember that at the point these people are sort of being taken advantage of, they're in active addiction, they're not really able to make particularly good choices, and they don't have a great understanding of how they're getting this help. And there's so much widespread offering of what they call them scholarships, I'll scholarship you into treatment. It's made to seem like someone is genuinely trying to help you out. So a lot of the people, maybe they think something's off, but a lot of them aren't 100% sure what's going on. And so they're not really aware explicitly of the insurance fraud.
We have a question from Ronnie Cohen, who says, can Dr. Humphreys and Dave Ehrenberg discuss what they see as the pros and cons of supervised safe injection sites?
Sure. David, do you want to go first? Or
Dr. Humphreys, you can go ahead.
Okay. So this is a fairly new thing. Some cities are talking about. There's the two ones that most people know about are in Vancouver, Canada, and then there's one in a couple in Australia. The research base is small, and almost all of it is based on those two programs, the Canadian program and the Australian program. The typical debate about them is, on the one hand, if someone overdoses, you're right there and you can help them, and save their life, like with naloxone. It could also potentially be a route through which people who are, say, homeless and kind of in the wind would be connected to the care system. The risk could be that if people participate, they make friends around their use, that their careers could be longer. And we don't know which one of those things is true. The research is pretty early, and it's mostly been done by people who are super enthusiastic and in favor of these programs. And in fact, usually the research is done by people who operate them. So I think that what would be a great thing now would be for someone like, government accounting or accountability office or some other objective body to take a look at them and see whether they could make a contribution to public health.
Yeah, this is Dave Ehrenberg. Yeah, that's well said. I don't have much to add except, we're trying to do a needle exchange program here in Palm Beach County to stop the spread of disease, but it's going to be tough to get it through the state legislature. We have a pretty conservative legislature, but we're trying. They're already doing a pilot project in Miami-Dade County, so we're trying to do it here. So if any attempt in Florida to have something like that would be almost impossible. I did go to some seminars where I heard it being discussed, and I'd love to see the results and the statistics, but I don't think that's going to happen in Florida anytime soon.
We have a question from journalist Aaron Glant, who says, can you explain how Florida is different from other states regarding doctors being able to purchase opiates?
Right, I can take that. This is Dave Ehrenberg. The law in Florida used to allow doctors to prescribe and sell opiate, dispense it, and that changed in 2010. And then you saw a dramatic decrease in the number of pills being dispensed. So doctors don't purchase these drugs much anymore because they can't dispense it except in limited situations. Now it's the pharmacists who dispense it. And in Florida, our prescription drug monitoring program only requires a dispenser to alert the program of when someone buys a Schedule 2 or 3 drug. So the doctor doesn't have to even check the database before prescribing it. The only one who in fact, no one has to check the database before prescribing or dispensing. The only monitoring that goes on here is the pharmacist who dispenses the drug has to report the sale of the drug within 7 days. So it's a very weak prescription drug monitoring program, but it is still working. And things have changed, though, dramatically. A lot of the pill mills ended when doctors were forbidden to dispense because the pill mills used to be one-stop shopping. You go in, get diagnosed, get your pills, and you're on your way. When we made it harder to do that, those places closed up.
We have a question from Shoshana Walter, who says, have you found the courts play a role in referring or ordering defendants to these types of rehab sober living homes? Are they aware of these scams?
Sober homes are totally unregulated, and courts will not order anyone into them. Courts may order people into drug treatment, drug courts, but courts won't order people into specific places like these outpatient centers or sober homes. There may be a requirement that they go to drug treatment, and then there's a list of legitimate providers. But we have not seen the court process being abused in this way. In fact, we'd love government to get more involved and less because of the ADA and all these other federal laws. Local governments can't even touch sober homes. It's very limited that what we can do in overseeing those places.
And we have a question from John Nyako Nayasani. He says, you indicated sober homes are not regulated in many states. How many states currently have regulations, and how many have a similar task force to the one in Palm Beach?
I don't know that answer. Maybe David or Evan can answer the other states.
Well, I can tell you that Massachusetts does do some regulating of sober homes. It's somewhat bare bones, but the state does require a license and does some checking. It has some minimum standards. But again, as Dave pointed out, Because of various federal statutes, it's very hard for governmental entities to take action and close down, some of the worst sober home offenders, unless they're doing something else wrong, insurance fraud or something like that. There may be other states that regulate sober homes in a very light way. I only know about Massachusetts.
And this is a related question from Christopher Johnson. Dave Ehrenberg mentioned the problem is expanding outside of Florida. Any sense of where else in the U.S. we're seeing these scams?
I'm hearing a lot. Oh, go ahead. I'm sorry.
Oh, sorry. Well, I mean, we've seen a lot of, people talked about California, Arizona, Texas, some areas in the Southwest and the West.
We have a question from Sally Balsamo, who says, are you aware that physicians treating legitimate chronic pain conditions are forcing responsible users off opioid medications due to fear of arrest and licensure suspension? How do you balance improving the illicit opioid addiction while still enabling chronic pain patients to receive needed medication?
I can address that. This is Dave. It's the pendulum that had swung one way, moved to the other way, and it made it a lot harder under new federal and state laws to get access to a lot of these prescription medicines. But, we still have more pharmacies allowed to dispense this than ever before in Florida. So I think the pendulum is starting to reach equilibrium where, it's probably the right balance. I know that it's not always easy for some people to get these pills, but a lot of that is because of the fear of doctors from the DEA and state authorities. When I have never seen a doctor get busted for distributing pills to legitimate patients. The cases that I've seen have all been way over the top, where the doctor is just a drug dealer wearing a white coat. And so there may be some fear out there, but that fear is not based in reality that those doctors are going to get arrested for providing drugs, prescription drugs to legitimate patients. But it is something that I think education, the word needs to get out, that the DEA is not going to be barging down the door for people who are treating legitimate patients. But until, I guess that equilibrium is reached, you're going to see some irrational fears out there.
Dele Solaru says, how can the loopholes be plugged and that the current laws in place do help the majority of people?
If I can answer that one too, and I'll be quick on this one. This is Dave Ehrenberg. As the last speaker said correctly, look, we need the Affordable Care Act to provide treatment for individuals in recovery, but the Affordable Care Act has been exploited by bad people. And the better way, I think, the best way to close the loopholes would be to look within the Affordable Care Act, which has a mechanism for rewarding providers under the Medicare program. The good hospitals, they get paid more than the hospitals that have excess readmissions. I think that we can create some sort of standard where the good providers get more money and the bad providers are penalized. You can do it through their success rates, and I realize that there's only like a 10% success rate in many cases, but you can do it through success rates and peer reviews. I mean, we all know who the good and the bad providers are down here. You can talk to us in law enforcement. We can give you lists. So I believe the government should be able to, just like they do for the Medicare program through hospitals, they can do the same thing for private treatment providers to pay the good ones more and the bad ones less. And when I say government, I mean government via the insurance companies, because they're the ones really reimbursing here. But it's government policies that have encouraged all this money to go to the fraudulent treatment providers.
This is Keith. I just want to generalize what Dave is saying is, addiction needs to be in the healthcare system so that it's subject to all the normal regulations we are. I mean, that these problems that have been described so vividly are not common in oncology. But oncology is very well regulated, it's very well staffed, it's part of the healthcare system, it's closely watched. And we're in this transitional moment where an industry that hasn't had that status is now starting to get some of the resources from insurance, but isn't yet being integrated enough that it's held to those standards. I think that's what we need to do.
I think that's the perfect note for us to close. I want to thank all of our expert speakers and our audience, and you'll be able to find a copy of this webinar archived on our site, centerforhealthjournalism.org. We'll also be sending to all participants a quick survey, and we ask you to take a moment to fill it out, as it really helps us design our future surveys as well. Thank you very much.
Thank you.
Thanks.
Thank you.